Welcome to our podcast, Making Clerkship Click, with your hosts, Tanmay, William, and Nick. If you're a medical student, this is a podcast just for you to get quick and easy primers on high-yield medicine topics that you're likely to come across when you go through your clerkship blocks. So let's dive right in.
Welcome to another episode of Making Clerkship Click. I'm Nick.
And I'm William.
And we are two of your three hosts of this podcast. Unfortunately, our third compadre, Tanmay, is busy with orthopedic surgery right now, fixing lots of different hips and knees, but we have his permission to record this episode without him.
Yeah, he's a big important guy around hospital, but and you as listeners only have to deal with us two today. But we got an exciting topic for you today. Sadly for our listeners, we're focusing on a problem that you're going to see lots of on your ER rotation, on your surgery rotation, appendicitis. Before we begin, we're going to start with a quick disclaimer. As usual, again, we're medical students, not medical doctors. This isn't medical advice. The information we're presenting here is based on lectures, research, and clinical experience. It's not meant to guide clinical practice or decision making. Now, Nick, I'm a man of very few strengths, and you also know that anatomy is not one of them. No. Can we start with the basics? What is the appendix?
Well, I can guide you through this as I'm an anatomy not expert. That's a bit of a
genius.
No, but I enjoy my anatomy. So the appendix is this small blind figure-sized pouch that attaches to the cecum, the first part of your large intestine, and it's present in the right lower quadrant of the abdomen. There's quite a large debate over why the appendix is actually still present in humans, and there's actually some research that suggests that it serves as this reservoir for beneficial gut bacteria. But overall, this little small pouch actually becomes a problem when it becomes inflamed. So, William, from your knowledge, what drives this inflammation of the appendix?
Yeah, well, it's pretty simple. Usually what drives the inflammation is obstruction of the appendiceal lumen. So to put it simply, the opening of the appendix just gets blocked off. And now this can be to a bunch of different things. It can be due to feces, little bits of feces called fecaliths, calcified deposits known as appendicoliths, enlarged lymph tissue after an infection in children, which is very, very, very common, or even tumors in older patients. In any case, though, the blockage prevents mucus from flowing out. That leads to distension and increased pressure within the appendix, which can also impair blood supply. To make things worse, the lack of drainage of that mucus really allows for a lot of bacterial overgrowth. And between all these factors, we have a perfect recipe for inflammation, necrosis, and if left untreated, perforation, which can actually drive the formation of an abscess.
Ooh.
So, Nick, let's say a patient's appendix has been blocked off by something. How are they going to present?
So for the presentation, a patient will typically have abdominal pain that is initially generalized. So it'll be around their abdomen, mainly centering around the belly button, or as us fancy medical students like to call it, the umbilicus.
Very fancy.
As this inflammation, fancy. As the inflammation progresses in your abdomen, it will extend from the appendix actually towards the parietal peritoneum. And with this, that pain you have actually shifts from being more generalized and actually migrates to the right lower quadrant and becomes very specific. Along with that pain, you'll also have poor appetite, and patients are commonly quite nauseous and they'll be vomiting as well. Beyond that, they can also have a fever as the inflammation worsens. Now, there's a couple of different things on the patient's physical exam that you can see that will actually point you towards a potential diagnosis of appendicitis. So the classic finding that you'll learn about constantly in medical school is tenderness at McBurney's point. And this is 1/3 the distance between the anterior superior iliac spine, or ASIS, and the umbilicus. Alongside that, you can also have something called a Rovsing's sign, where you actually palpate the left lower quadrant, and this causes pain in the right lower quadrant. So a bit surprising, but it's a common finding you can see in appendicitis. Another finding you can have is the psoas sign, where there's actual pain you can elicit when you get the resist flexion of the right hip. And finally, you can have the obturator sign, where actually the patient will have pain when they flex the hip and also internally rotate the hip. Those together can cause pain.
But Nick, there's an important side note, right? As you know, all throughout third year, one thing you really have to learn to do is to keep your differential really, really broad.
As always, yeah.
as always. So it can be mimicked, like this presentation you've just described can be mimicked by a whole bunch of different other things. So you can have like gastrointestinal conditions like gastroenteritis, colitis, IBS, diverticulitis. You can have urological issues like kidney stones that look like this. You can also have gynecological and obstetrical problems like tubal ovarian abscesses, pelvic inflammatory disease. And really, really important thing to think about is ectopic pregnancy. So it's important to keep an open mind. Don't come to conclusions too rapidly, or sometimes you can end up misdiagnosing the patient and doing harm. So Nick,
Yeah, being broad is best.
broad is best. You should. I'll get that tattooed somewhere, Nick.
Please.
You know, it's a one of the classic Nickisms that I should remember.
Of course.
But Nick, so Nick, let's say you're in the ER. The patient comes in, they have migrating pain, right? So they have that generalized abdominal pain, and then it eventually becomes specific. They're very, very nauseous. They're vomiting. They have a fever. McBurney's point is tender, and Rovsing's sign is also positive. So here, what investigations you want to order?
So first things first, what I'm going to do is I'm going to think back to that quote I gave, broad is best. I want to get some broad investigations to look at a number of different things. I'm not just pinpointing appendicitis and we're good. I wanted to get a lot of different investigations. So first, for blood work, the key things I want to order include a CBC, or a complete blood count, along with a differential. I also want to get a CRP to look, and with these I want to look to see if there's an elevated white count and a high CRP, and both of those will tell you that there's likely some sort of inflammatory process somewhere in the body. Non-specific, but tells you there's inflammation. Beyond that, I also want to get a beta HCG to rule out pregnancy if the patient is female, as if they are pregnant, that can have an impact for your differential diagnosis, what imaging you use, as well as your treatment plan. Also, I want to get a urinalysis, as that can be helpful to try to exclude potential urological causes, like you mentioned, that can cause that sort of pain and discomfort. From an imaging side of things, the CT scan of the abdomen and pelvis is the most accurate test to look for possible appendicitis and look for many other different causes of this sort of symptoms in patients. Though, if you suspect that a child has an appendicitis, or if your patient is a pregnant female, ultrasound is actually your best bet in terms of testing, because you don't want to expose this population to unnecessary radiation.
And that's why the beta HCG is so important, right, Nick?
Yeah, of course. Yeah, that's why you want to rule out pregnancy first before you decide, okay, I'm going to put this patient in the scanner and expose them to a ton of radiation that could be harmful to their developing fetus. So now shifting towards management. So we've run all these tests on our fictional patient. We find that their beta HCG is negative, but they have an elevated white count, as well as their CRP is high. You do your CT scan, you see this inflamed, non-perforated appendix. So William, with all that in mind, what are you going to do for them? What management are you going to start?
All right, the listeners are going to get sick of me saying this, but you're always going to have to start with the basics. So ABCs and vitals. So is their airway patent and open? Are they breathing well, and are they oxygenating? Are there signs of circulatory compromise with a high heart rate or a crashing blood pressure? Patients with severe appendicitis can become really, really sick. They can become septic. So it's important to be methodical and careful with your management. In general, though, you're going to do a couple of different things. You're going to start every patient on IV fluids. You're going to provide them with some kind of medication for pain control, and you're going to start them on antibiotics. So for uncomplicated cases, you can go with the classic combination of ceftriaxone, which gives you good gram-positive and gram-negative coverage, as well as metronidazole, which helps cover you for gut anaerobes. Finally, you're just going to consult general surgery and make them NPO for surgery. So Nick, you as a surgeon, you come in, what are you going to recommend?
Well, if I was a general surgeon, the most beautiful of all surgical specialties, generally what I'm going to do is I'm going to see this patient, I'm going to assess them, and then if I think it's appendicitis, I'm going to recommend removal of their appendix, and this is called an appendectomy. This is really the gold standard for treatment. So nowadays, this procedure is largely done laparoscopically through these tiny incisions, though if you have a really, really nasty case of appendicitis, like something that could be perforated and you can have this abscess form, you may have to actually do it open, which is more significant surgery and results in a longer recovery time. Now, a caveat to all that is if you have a healthy adult patient in front of you and their appendix is non-perforated, Conservative treatment actually with antibiotics is a safe option. But there are some risks to this approach that we won't get into that today on the podcast. But if you're a general surgery keener, there's some growing debate between surgical versus non-surgical management of appendicitis. And there's some interesting articles that support the different sides of this debate that you can look up in your free time. So something to read up on if you're interested in general surgery like me, but if you're like William, who loves general surgery, but he's more of a pediatrics man, just trust me that there's an interesting debate now between those two. So we've gone through appendicitis. We've talked about the physiology and the pathophysiology. We've talked about the patient presentation. We've talked about what investigations you might get and the management you'll likely proceed with in a patient where you suspect appendicitis. So William, let's go over a quick summary of all that because it's a lot of information to pack in this short episode. So what exactly is the appendix? What exactly is the appendix?
So the appendix, again, is a little finger-like pouch on the large intestine, which can get blocked off and become inflamed. And when patients present, you'll see this like a pattern of migrating pain, which starts as generalized abdominal pain and which gradually moves towards that right lower quadrant. You'll also see nausea and vomiting, decreased appetite, and fever.
Next, in terms of the physical exam, in most cases of appendicitis, you'll see that McBurney's point will be tender, and that's that point that's 1/3 of the distance between the anterior superior iliac spine and the umbilicus. Beyond that, you also see the additional special tests like Rovsing's will be positive, as well as they might have a positive psoas sign. In terms of investigations for a patient with suspected appendicitis, you want to order a CBC with differential, a CRP, beta HCG to rule out pregnancy, as well as a urinalysis to exclude potential urological causes of the presentation. Next up for imaging, CT is the gold standard, but you have to use ultrasound in cases where you're concerned about radiation exposure to the patient, like in pregnant females as well as in children.
Okay, now to manage, as always, you can start with your ABCs and vitals. In general, though, you're going to give fluids, pain control, antibiotics, so again, your combo of ceftriaxone and metronidazole for uncomplicated cases, and refer to our good friends in general surgery for appendectomy. So Nick, I think that's all we have time for today. I think that was a pretty good episode, no?
Yeah, I think we gave a beautiful summary of this very common condition that you'll see in lots of different rotations. And whenever you're suspecting appendicitis and you have seen the patient and assessed them and made sure they're stable, like William said, make sure to call general surgery.
There we go. I'll talk to you guys later.